we need more primary care doctors than we currently have. So I think the primary care shortage piece definitely, I felt that very deeply when I was making this decision, feeling like I was contributing to inequity in access, or that I was, I had taken a spot in a primary care program that ultimately didn't end up yielding a primary care physician. I think it's just a reflection of the hard choices that we're expected to make when we're, sacrificing some element of personal satisfaction or work-life balance in order to do a thing that is honorable and best for patients.
Today, we're going to be talking about those hard choices, meaning why has it gotten harder for trainees like Priyatha Narasimharaj, who goes by Pri, to embrace careers in primary care. Pri is a cardiology fellow at Beth Israel Deaconess Medical Center where I practice, and I do want to start by saying that I really believe good doctors are needed in every specialty, meaning being an excellent surgeon or oncologist or even a cardiologist seems no less honorable to me than being a primary care doctor for the underserved. But I also understand Pri's guilt. It's estimated that nearly 1/3 of Americans don't have primary care doctors. And as the population ages and more physicians retire or leave traditional practice, workforce shortages loom large. The obvious remedy is to increase the number of clinicians entering primary care. But a lot of people who enter medicine intending to practice primary care end up walking away. And who can blame them? Their primary care mentors are burned out. They're constantly told they're going to be replaced by AI. And their friends in med school planning careers in dermatology or ophthalmology seem destined for happier and more lucrative lives. Which is all to say, is the declining appeal of primary care mysterious? On some level, no. But as much as I think trainee choices reflect the realities of our broken primary care system, I also think that explanation is incomplete. And so today we're going to be talking about why. I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. Pre-trained in a primary care track, and in explaining what happened during her residency that ultimately steered her away from primary care, she emphasized that even though a trusting doctor-patient relationship is central to primary care, as a resident, these relationships are harder to forge. Patients, who often get passed from one resident to the next every 3 years, may be skeptical of the young doctors. And because residents, too, are just there temporarily, they get less exposure to the gratification that often accompanies long-standing relationships. But Pri also talked about something I remember distinctly from my own residency, which is the whiplash that trainees experience going from the inpatient setting to outpatient practice.
Yeah, I think most primary care residencies are ill-equipped to train primary care doctors because you are constantly being pulled back and forth between the clinic setting and the inpatient setting. And the inpatient setting almost always feels more urgent, interesting, important, compelling. And I think that comes up time and time again, where resident primary care doctors are often triaging things on their day off, or they're triaging things, at the end of their night shift when it's morning because they can call a patient back before they go to bed. There's no way, I think, to have that kind of experience and not have resentment towards the intervisit work, especially because it's often things that are less urgent clinically, like a patient who's messaging you about UTI symptoms after you've just run like a 4-hour code and, seen a patient die and process that with their family members and your team. It's just a very jarring shift.
Pri also talked about something I heard from primary care clinicians across the board, which is how decimating the pandemic was for primary care.
I ended up training in residency during most of the COVID pandemic, and I think seeing the clinical infrastructure start to wear down as a result of all of these external pressures, noticing that relationships among clinic staff felt more fraught There was a lot of turnover, so people that you felt like were really adept at making clinic run on time and, rooming patients and triaging their needs, like those people would get burnt out and leave because they wanted jobs that were more sustainable to them, which totally made sense. And then having to redo that whole system over again with a new set of clinic staff. As residency wore on, there was just more and more evidence that primary care was unraveling even during the confines of, 2 or 3 years. And so that was really demoralizing. This is different, I think, depending on where you train, but I trained at a very academic program. And a lot of primary care mentors who I really respected, who were also doing policy work and research work, were only doing primary care like 1 to 2 sessions a week maximum. Even they seemed burnt out by the clinical workload of primary care. And so I think that made me also feel very apprehensive because at that point in time, I was anticipating a career of majority clinical work. And I was starting to feel pretty worried about how quickly I would burn out if I transitioned to full time primary care after residency.
It seems to me like no matter what we do to change training for primary care, we cannot get around the fact that trainees are making a rational decision. They are looking at their mentors. They are seeing that like actual quote unquote full-time primary care, which is truly part-time primary care because everyone knows like full-time is totally impossible, is not a happy life for most people. I think there are exceptions. And so to say like, okay, we need to expand the workforce, fine, like we do, that would be great, but it doesn't seem like it's feasible until we fix primary care itself and so that trainees can look forward to a more gratifying and less unhappy life.
Yeah, I think that exists in all of clinical medicine, but I don't think there is a field where it is more often brought up than primary care. And I think it's all of the things. It's the logistical issues, it's the dissatisfaction that I think some primary care doctors feel about not being recognized as experts either by their patients or their colleagues. I think there's a lot of tension between subspecialty providers and primary care when both sides don't know how the other person's approaching the problem. And then I think lastly there's a delayed gratification when it comes to seeing some of the outcomes that you can expect to see as a competent and engaged primary care doctor. I think it takes many, many years to become truly comfortable in your scope of practice. And like you said, most trainees are making rational decisions based on the information they have, which is 18 months of trying to be a primary care doctor versus 18 months of being a very efficient hospital based clinician. So I think it does actually, I think, require a bit of a leap of faith to say, here are a lot of reasons why primary care is really challenging. I haven't yet had the opportunity to see the good things, but I'm going to make that decision anyways.
One of the things that I remember most from residency, so my primary care clinic, it gave me tremendous anxiety. Like I had way more anxiety about clinic than I had about anything else. And I'm still trying to figure out, especially now as I look back, why that was. And I think I'd love to hear what it was like for you. For me, one thing obviously is that you can get things done in the inpatient setting. You have exquisite control, it feels like often. I mean, sometimes you can't control people's illness, but you can control what you can and you can't get done. And I felt like in primary care, I didn't have control. And I remember like the first time I went home, it was like a 6-hour plane ride and I fell asleep and I like had this dream about all these pap smear path reports coming back to me and like in my inbox that I'd never seen and that I was like missing malignancies. And I remember that dream forever. Like it was on the plane and I always felt like I didn't have a system. Like nobody, you don't walk in the door and someone says like, here is a system for managing results and like the pace that you should use and how frequently like you should be checking and if you should call people like when or not to and should you give them your phone number and all these little things that people develop their own styles about. And I don't mean that in a way like that we need to be spoon-fed, but There is such an intrinsic system in the inpatient setting. And I'm wondering if that was something also that you experienced, or maybe we've gotten better at that and you were in a primary care track, or was it similar?
I think it was very similar. I think the loss of control and the challenge of understanding urgency in the outpatient setting, I think. I was always very reluctant to just send people to the emergency room because it's everyone's least favorite place to go. But I think that awkward middle ground of this is concerning and I haven't yet built a framework for how worried I should be about any number of results that could arrive in my inbox on a Friday afternoon and having to make the decision and feel the responsibility of do I sit on this? Do we sit on this until the next week or do we just bite the bullet and recommend that they go in, to the place where you have a lot more control? I mean, I think I had a preceptor who was really hands-on and really invested, and so at least it was easy to contact him and get his help with all of this.
Because of Pre's policy aspirations and her proximity to training, I asked her what she would do if she could somehow run a federal office of primary care to address some of the training challenges.
I think there's something to be said about master clinicians who are primary care doctors and elevating that role. Some of the smartest doctors I know are primary care doctors. And I think that goes very underappreciated because a lot of these grand rounds, master clinician series focus on subspecialists who have such narrow scope and are sort of like put up on a pedestal as like the people that we all need to become. And I don't know how to enforce this top down, but I think identifying really excellent primary care doctors in the academic or community setting and somehow having them offer us a window into how it is that they do what they do and how are they so good at it, I think would at least help trainees understand that the burnt out primary care doctor that they're working with is not the only model for primary care. Like you said, I think it's a hard problem to solve within just academia. And I think some of the best primary care doctors are not in academia too. And I think that's also what makes it hard because we see such a tiny sliver. If I got to go to rural Alaska and see how full spectrum primary care was practiced, I don't know that I would want to move to rural Alaska, but I would probably learn a lot more than from a primary care clinic that just refers patients to every specialist that they want.
I totally agree with Pri that more exposure to community-based primary care clinics would likely increase the appeal of primary care for a lot of trainees whose exposure tends to be limited to academic settings. But one of the more surprising things I learned in my reporting on primary care is how little funding such community-based programs receive. Bob Phillips, a family physician, policy expert, and executive director of the American Board of Family Medicine, explained a bit more about how graduate medical education dollars are allocated and why primary care so often loses out.
So graduate medical education, how we train 44,000 physicians a year, is funded largely by Medicare, but it's also funded by Medicaid and it's funded by the Veterans Administration, Department of Defense. It's a $23 billion annual funding stream for education, largely controlled by academic health centers. So we're training our future workforce almost exclusively in hospitals with very little outpatient training, very little community-based training, certainly very little rural training. There is a small $500 million funding stream off to the side to teaching health centers that comes through appropriations rather than the Medicare entitlements. And those are community health center, community-based hospital training programs, and they have far better outcomes for producing primary care and people who take care of underserved. If the financial model of an academic health center is really focused on its high-priced services, well, that's where their GME dollars are going to be put because they need that residency trainee workforce to staff those models. And so we have seen a shift towards those in the training model. We've seen a shift to training more in the hospitals. And those trainees are far less likely to go into primary care or outpatient care as a result. And that's where we've resulted in internal medicine dropping from a quarter of general internists going into primary care down to about 10% over the last 15 years. So our $23 billion of taxpayer-funded physician education is largely going to produce the workforce for a health system that is increasingly subspecialty focused.
For all the people out in society who can't get a primary care doctor, do you think any of them have any idea that $23 billion worth of taxpayer dollars are essentially going to fund lots of specialists and hospitalists and very few primary care doctors? Because my sense is there's very little understanding of this, both within medicine and in the public.
I think they have no idea. Related to that, we just published a study asking American citizens how much of total healthcare spending they think goes to primary care, and they said half. We know it's 5% or 7% in commercial spaces at best. I think that misunderstanding applies here too. I think they have no idea how much is spent on physician training, and I think they have no idea how it's being applied to meet their needs. And if they did, they'd be upset.
Where does accountability lie? Like, do the AMCs have any responsibility for which they're held accountable to produce primary care doctors?
The answer is no. Actually, Medicare, which is 16 of the $23 billion, is actually not allowed to say anything about the kind of workforce that money is supposed to produce. And that's a real problem. And it is congressionally fixable. You could modify that so that there were measures and expectations for that money.
I do think addressing this funding misallocation is one of the more fixable aspects of the waning trainee pipeline. But I also think all of the GME dollars in the world can't fix some of our cultural challenges that also affect trainee choices. And one of those challenges has to do with primary care's reputation as a means to achieving social justice and reducing inequities. We heard Pri describe her guilt about not doing primary care, given its social justice orientation. The corollary of that, however, is the frustration that some may experience if they don't sense they're addressing inequities in the way they once imagined they would or could. I heard this kind of disappointment from a lot of trainees, but I also heard it from educators. Here's Ben Davis, who directs the Swedish First Hill Family Medicine Residency in Washington State.
On the large scale, I think that's where a lot of the frustration happens for residents, for new physicians, especially, in residency, you do a lot of inpatient work. And I think inpatient work, you see a lot of what is unseen in the popular media, which is like you see patients who have no PCPs or currently have no clinics or are struggling the most with addiction or whatever it may be, a large unhoused population. And a lot of people end up coming to the ED and they get admitted. And in residency, you're doing a lot of that work and you see it over and over. Patients get readmitted over and over. And a lot of the times it's not a strictly medical issue. It is a logistical issue. It is they don't have adequate resources to attend their wound care or to have housing or have refrigeration for their medications or whatever it may be. And you constantly get beat down by having to take care of these patients and then feel their frustration and feel their sorrow and their lack of autonomy. And you absorb a lot of that. And over time, like you can only take so many hits before it starts seeping through your skin. I'll say for like my residents, a lot of them get that experience, unfortunately, because of the patients that we choose to serve. And that can be taxing. And so I see a lot of residents after residency do locums. It's rare for me now to see a resident go in and say, yep, give me that 1.0 FTE job right off the bat. While I would say 10 years ago, that's much more common. Now, 70, 80% of our graduates would go just take a full-time job somewhere. And it's definitely less than half now that I'm seeing.
I think this is really important for so many reasons. First of all, figuring out why people who train in primary care aren't going into primary care, are trying to do less of it, but also the role that the aspiration, I think, to impart justice into this world plays in all of this, because I think it's complicated. Let's just take this problem of primary care residents training. I read some statistic, I think from a Milbank scorecard, as I was writing about this, that 3 to 5 years after they graduate, only 21% of residents who trained in a primary care track are actually practicing outpatient primary care. So you suggested part of that is because they're just getting beat down by the sense of maybe futility is what you're getting at, that they're seeing all these patients who come back again and again who aren't being helped. One could have an experience like that and have the opposite reaction, which is I could help them. I could be out there. I could be their primary care doctor. Maybe there is something I could do to prevent these readmissions. So I suspect there are other factors at play. And I'm curious what you think is driving what I think is a decline in the amount of trainees who are training in primary care and then actually practicing.
So I will speak to the best that I can, but fully knowing that I don't speak for every single person, and especially every single person who ends up quitting primary care or medicine altogether. I will say I'll double down and say I do think the futility and justice piece, if we have a Venn diagram of the people who want to go into family medicine and also the things that they're exposed to and then the things that are causing moral injury, there's going to be a lot of overlap because a lot of people go into family medicine to work with marginalized, underserved communities, but they get that exposure and they really want to move the dial and then they can't. And then it can be frustrating, right? I went into this work to move the dial and I'm not doing anything, or at least, I should say, it doesn't feel like I'm doing anything. I would argue day and night that you are doing something. I would suspect a little bit is the desire to see change and see it now. I think it's hard for a lot of people, especially residents now going into training intentionally to impart more justice in the world, to not see results quickly. And that's a tough lesson. And I think we all navigate that differently. I often will have discussions, especially with residents who are passionate about advocacy or leadership, is you got two ways of going about it. You can just burn the whole thing down, right? You can take the external approach and try your best to just change everything now, or you can take the internal approach, which is I'm going to be much slower, much more methodical. I'm going to make allies, even potentially with people I don't like or agree with, but to try to slowly impart long-term change in my organization and then eventually parlay that into maybe more change systemically. I don't think there's a right answer. I think probably the answer is both, and you just got to pick the right time and the right place to do both of those. I will say my bias is this latter approach, but I fully know that that's not the approach that other people may want to take, and that can cause burnout, moral injury, general attrition in doing medicine. There's the classic things, right? Primary care doesn't pay enough. There's inbox creep, right? You're always doing something and that doesn't get acknowledged. I think those are also valid, but I think there's probably a larger narrative in terms of what I'm at least seeing myself of when there is a resident who's struggling to sustain themselves, or for physicians, new graduates to sustain themselves. I think it's more the general futility of feeling like they're not seeing the change that they want in the time frame that they want to see it in.
So I think that this is really important because I think that we need to figure out why physicians are not practicing primary care. And I think some of it for sure is that the system has made that experience miserable for a lot of people. And that's something that we need to address as a society, as a healthcare system. But you're getting at something that I think is very different. And I think it's important to talk about because it is about narrative on some level. And I think if I'm understanding you, you're saying there is an expectation when you choose a career in primary care, but in family medicine, I think specifically it draws a certain type of person, that it is an act toward social justice. And what you're observing are people who are getting beat down and feeling like whatever work they're doing isn't having that impact of justice that they imagined. And what I'm wondering, have we set too high of expectations of what it means to achieve social justice? I have a friend who is brilliant, and we were talking about this because he studies inequities and he's done some incredible work identifying racial bias in machine learning algorithms. So he's really trying to address inequities from a science standpoint. But when we talked about what it means clinically, He said, being a doctor is an act of justice. And that stayed with me so much. Like, I think it's true. I think that we're just so much more likely as individual physicians to impact someone's life at the bedside than we are to like get our healthcare system to decide, or for our society to vote for Medicare for all. So if people are feeling disillusionment or a letdown because they're not enjoying their clinical work, because they don't feel like they're working in a system that allows them to give the clinical care that they can, that is one thing. But if people are feeling disillusioned because somehow like we gave them a sense that they would like become family medicine doctors and homelessness would go away or drug addiction would go away, that might be a problem with our narrative, our expectations. And so I'm curious how you think about that.
I would frame it like we should absolutely keep that bar as high as possible in terms of what the goal is. I don't think that we should lower the standards for how people are taken care of to have ourselves feel better. That being said, I do think if you deeply personalize that mission and that goal, it will burn you out.
Of course, other forces might burn you out too. And at some point, a point that may be different for everyone, you do get so burned out that you walk away. Wright Clarkson is a family medicine resident at Virginia Mason Franciscan Health in Northwest Washington, who's decided to practice hospitalist medicine rather than primary care. And so I asked Wright what for him proved untenable.
I think it can be broken down into a couple of buckets. The first, I think one of the more pressing is in-basket management. My specialty is laden with a lot of extra work that we actually don't see compensation for. And a lot of that work, I can attest to over the past year and a half, is intense, and it does require a lot of time, sometimes hours into the evening. Like I'll be eating my dinner while I work, and there's no reward outside of the help you can offer. And oftentimes, compared to what you can do in person, it's not nearly as significant. So it feels like a lot of low yield hours required.
The second thing Wright described is how unaffordable it has become to open an independent practice. And he focused specifically on the enormous expense of a high-quality electronic health record. Although a lot of us complain about the EHR burdens, what Wright pointed out is that if you don't have a good one, it's way harder to be an effective physician for your patients. And a good EHR costs a lot of money. EHRs are certainly not the only financial hardship independent practices face, but they've certainly contributed to the financial insolvency many independent practices have experienced. And Wright made very clear that if he could practice independently and not be beholden to a large corporate employer, he would want to practice primary care. But the third thing Wright talked about in explaining his own change of heart is the factor I find most fascinating and also most perplexing, which is how much we in medicine and society devalue primary care.
I think the last bucket, and this is something that is a little less approachable and personal, is the sort of interdisciplinary respect that gets shared between healthcare practitioners. I think, firstly, I'll say money is representative of what society values, right? So the specialties that get paid more often do require more work, but they pay out more because society values their presence a lot more. And I definitely see a shift in the tone about which people talk about primary care, in the sense like, why can't I find a primary care doctor? Where are all the primary care doctors? What's going on? Well, that's because you have demonstrated to anyone who would have been a primary care practitioner that you don't value that position very much over the last 30 years. It has been the least paid specialty. It has been the least respected specialty within medicine. And so when you have a new resident who's open-minded come into this field and really practice within it, no wonder more want to go inpatient. It's just easier. It's more respected, and it's more paid.
I want to hear from you what that looks like to be devalued, to be disrespected. How does that get communicated to you? Is it from patients? Is it from your peers in medical school? Was it from attendings telling you what to do or what not to do?
It's all over the board, honestly. It's kind of baked in. the first place you'll find it is within the specialty itself, I think. It's gotten to the point where it's been so long that like we don't take ourselves as seriously as I think we could at times. I think there's a lot of jokes about referring up the ladder. You always have that referral up the ladder. I'll say that's not in my program. My program is very focused. When I say we, I mean as a specialty. So like walk into an urgent care, the doctors there who have just become settled in to that type of environment. And that's not a jab at urgent care. That's a jab at the results I have seen from urgent care referrals within my own healthcare system. You see a lot of just referrals out because they don't have the time or the resources or the attitude, the inclination, however you want to look at it, to build that same broad differential. And that could be because it's just a quick, 15-minute, 30-minute visit. But regardless, that's what family medicine is being transformed into on some level. So I think there is an adopted attitude of sort of lackadaisical approach to medicine within it that is dangerous and also underutilizes and teaches physicians, APPs, whatever, to underutilize themselves. They become adjusted to a sort of expected encounter and expected outcome, like algorithmic thinking in a way. There's not a lot of creativity or problem solving there. They're just here to either get them to the ER or maybe throw a couple sutures and see them on their way. And that would be terrible for family medicine to go further in that direction. That would undermine everything family medicine is supposed to do, which is to identify rare things, dangerous things before they become dominant in someone's lives. Hopefully get them treated by a specialist if they cannot figure out the answer on their own. My residency program is very focused on the opposite of this, on building broad differentials within even a 15-minute framework, which honestly, kudos to them because it's really hard to do. But regardless, I think the first place to address it is within the practitioners itself. I want to see less practitioners who are just okay with like, okay, I can't figure it out, let's refer it up. I want more of that go home and think about it attitude. I want more of the drive to build differentials on our own and treat things on our own within boundaries that are safe, obviously.
Wright also talked about sometimes being disrespected by patients.
These attitudes that you experience specialty to specialty are fed to patients in one way or the other. And it's definitely been the perception, I think, for the entirety of my career that family medicine is a little brother specialty. Oh, you got a cut finger, go see family medicine. Oh, you need a well child check, go see family medicine. They'll take care, their chart, family medicine will take care of that. It's just like bottom of the totem pole within a system where it honestly could, if you made that, whether through monetary policy or through attracting some of the most bright physicians, it could be the top of the totem pole. And you would see a significant shift in healthcare outcomes within the country if that were the case. So I don't think the patient populace, that's not where this attitude starts. I think it started within medicine and was fed out. But regardless, we are to a point where, yes, people are like, this is just this guy, he's MDD, I don't care. He's just here to fill my antidepressant and that's it. But there's so much more if we approach it with a different attitude, this time from the patient perspective. What if a patient approached a primary care visit with the same sort of intensity that they did something surgical? There would be better outcomes.
What we're trapped in is this weird vicious cycle where we've undervalued primary care for so long that it can't function. It can't do all the things that family medicine once did and do them well. And then that engenders, I think what you're describing within the profession is this sort of like point and click, refer out. We've been disrespected for so long. We have 15 minutes. Nobody's going to pay us anyway. Why bother? And then that approach then gets rebroadcast out to the world and fuels more disrespect. And then that just happens over and over and over. And I don't know where to abort that cycle. That's where I'm stuck. I don't know if you have any insight into that.
It comes down to monetary reimbursement. The money a specialty receives should, in theory, be representative of how much value they are bringing a society. So I think there's room to experiment within healthcare. We have this hierarchy that obviously values acute resolution more than prevention. The issue is there's this divorce of time. It takes a long time for preventative strategies to play out, and it's often not as gratifying. You went to sleep with a single nodule of something in your body and now it's gone and you feel better. There's a difference. That acute relief is massive. And I think ultimately that's what our society values more than the prevention of that acute problem in the first place.
I mean, it's a psychological problem of the human mind, I think, a conceptual problem, because if I don't have a heart attack tomorrow, I'm not going to be sitting around thanking my primary care doctor. It won't register for me because it didn't happen. And I think all of prevention faces that dilemma. It's very hard to value things that don't happen. Can you tell me, you chose family medicine, you matched into family medicine. I assume you went into it thinking you were going to have an outpatient family medicine practice. Was there a moment when you changed your mind, or was it an accumulation of many moments? Like, when did you have clarity that you would not be practicing outpatient family medicine?
When I was in medical school, I had more time with my patients, which just makes sense. That's normal. You're a medical student. You don't have as much to offer. But there would be these situations where they would just stick me in a room because they knew I would talk to a patient. I would keep talking to a patient until we figured something out or I built rapport. And then once you build rapport, you're not just limited to advice with regard to medicine. The floor is open. You can help someone with anything if you have solid advice to give them. So I'm used to these 30-minute to an hour-long visits because I figured this is what this family medicine practice is letting me doing. I liked my inpatient rotations with regard to what family medicine could do there. I liked the obstetric rotations I had, so I made the decision. Come to find out, by third year, you only get 15-minute slots. That is just not something I was prepared for. I don't think it was as common as it is now. Maybe it's the system I'm within, but I do see it becoming increasingly common, like the 15-minute get them in, get them out visit, get a referral, get them out.
The last thing Wright talked about when it comes to why trainees may walk away from primary care is a factor that I think deserves way more attention. And that's how we, in medicine, treat each other.
For instance, I met a cardiologist back home in South Carolina, and this was after hours, right? Because when you're working, it's a little bit different, but it's those less formal environments, the real attitudes seep out. And he was like, "What are you going to be?" Because I was probably a first year, second year medical student. "Oh, but not a psychiatrist, right? Not a PCP, right?" And I was like, "Okay." I mean, I was considering both of those, but now I want to say something different. Now I want to be different. I want to offer something different because this is someone who's trained a lot, and I want them to recognize that I'm also trying my best. But, I don't want to use a charged term, but it is a sort of microaggression, almost like it just feels belittling. And that attitude I've seen manifest in almost all specialties. Heck, I've heard of neurosurgeons saying that all PCP positions will be replaced by AI. And that was probably 3 years ago. Why are we saying things like this to each other? As a community of healthcare practitioners, who ultimately does that support outside of the people in your own specialty or, honestly, your own ego? It is a systematic putting down of a specialty that is perceived as less. There would be tremendous benefit both to society with regards to monetary policy as well as patient outcomes if we just got rid of the bullying or the pseudo-bullying in between these specialties versus primary care.
I could talk about the culture of medicine forever. What we value, what we don't value, and how those values came to be. And the more I thought about the systematic undervaluing of primary care, the more confused I became. Why would the people who are asked to do the most, who are the face of our healthcare system, be valued the least? I can't promise to answer that question because the truth is, I don't know. But I certainly think that drawing talented physicians to primary care requires that we better understand how these values play out in our daily lives.
This is where you hear, the thing that people dread, like you're too smart for primary care. or people who are looking at the different clinics that they tour through in a hospital. They go to the resident primary care clinic, and it's not very nice. Equipment isn't there or isn't working all of the time. They go to the specialty clinic that's like in the glass tower. It's very nice, very well staffed, and they see how happy the physicians look. Maybe they know what kind of cars they drive. They see them in the parking lot, and it's hard to ignore these things, even if income isn't like explicitly discussed.
I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. Our editor is Debbie Molina. Our producer is Mary Rose Madden. Adam Strauss is our audio engineer. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize this season and to identify the most pressing and unexplored challenges facing primary care. My new article series on primary care can be found at NEJM.org.